Thank you, Larry. Thank you, Dan and Mike, and my other constituent podiatry CAC reps. I think that today is actually going to be a little bit different, but I do first want to sort of honor your commitment and ask you, how many of you are carrier, or I should use the new terminology, contractor advisory representatives? How many of you serve right now? So great. And how many of you are thinking of taking on the task? Are there any new nascent developing CAC reps here? Well, wait, you guys then have to pass on the message, but don't tell them that actually it's getting a little bit harder. I think some of you have probably heard this talk before, but this year it has really changed a bit. And as I mentioned, I'm sort of moving on from a meeting here to another one, and next week out to the AMA. I think this has been a year of change. You know, people always are saying, oh, there's changes coming, and you don't see much happening. And then all of a sudden you hit a point where things do change. And this is kind of a fascinating dynamic, because essentially what you have here is change that was initiated in one administration essentially being flipped over and enacted in a new administration. So what I'm talking about here is the 21st Century Cures Act. How many of you have heard about it? Anybody want to offer up? Sir, you raised your hand. Do you have any understanding of it? No. And okay, that's an honest answer. I don't either. But the 21st Century Cures Act was meaningful legislation that essentially developed out of initiatives by the pathology community, and particularly involved molecular diagnostics and some of their evolving fields. But it essentially challenges us as contractor medical directors to be more transparent with you, to explain our rationales, and to tell you and the general public and stakeholders what we are thinking when policies are developed. And that is a little bit of a departure. And I think that those changes are going to change the way we work together a little bit. And so bear with me, this is the second time I use the same talk. I'm going to talk a little bit about vitamin D metabolism. And I'm sure that's high on your priority list, but I think that you'll see how it fits into being an ideal CAC representative in the 21st century. All right. Well, first of all, as I said, it's an outdated term that we're now Medicare administrative contractors, because we have Part A and B relationships and service. So instead of a carrier, we're now representative as MACs, and we're contractor advisory committees. I always open with homework, which is to read Chapter 13 of the Medicare Program Integrity Manual. It's about 37 pages long. About 12 of them actually apply to you as CAC reps. It's written actually not in legalese, but in pretty good, understandable language defining your responsibilities. And it will also talk about the three major objectives of the Carrier Advisory Committee. What I'm also going to do, though, is assign a little extra homework for all you CAC reps, and that is to look at a policy of ours, DL 37535. Now, hopefully, since we have all the veterans here, all of you know how to access the Medicare coverage database, correct? Good. Okay, then do that when you get a chance. And you will see that this policy is about essentially ordering analysis or diagnostic tests regarding vitamin D metabolism. Now, what I'm really supposed to be talking about today is what makes you a good carrier advisory rep and how do you relate to us to be more effective. Well, first of all, vitamin D metabolism, or aberrancies thereof, is how some of the patients get into your offices. I mean, I think that this is one of those examples of a policy where we would really appreciate Mike and Dan and others of you to comment on the policy from your perspective, from the perspective of your profession, because it does involve your patients. And I think we really value those CAC reps that come, and even if there's not a policy on debridement or avulsion, that you've taken the time to come and you're thinking about how these new policies impact on your practice, your specialty, your profession. So when you sign up, and I'm preaching to the choir here, you're signing up to also think about and help us with other policies that don't clearly initially seem to affect what you do. And I would aver that there's a lot of things, anesthesia policies, orthopedic policies, things we've done over the years where you have made a contribution. So pass it on to your recruits that if you are going to work with us now, we need your comments more than ever. Now, when you look at DL 37535, you're actually looking at the original subject matter work of Dr. Arthur Lervy. So we must have some Noridian people. Some people can. Great. You know Dr. Lervy? Yeah, good. Okay. Art practiced endocrinology in Los Angeles about as long as I practiced medicine in the Alexandria suburbs of DC. So we'll go through the thinking process of a policy and where your input is going to make a difference in the 21st century. First thing that happened was in California with point of service lab testing, there has been a great uptick in the data in the use of vitamin D assays. So what triggers a policy? Many times changing or aberrant utilization, possibly inappropriate utilization, guaranteeing access of a service to beneficiaries such as flu shots would be an example of maybe we want to direct beneficiaries to the right type of treatment, high ticket items, new technology, where there's inappropriate, where there's unclear correct utilization. So those are things that trigger the policies. In this case, in New York and New England, we had similar increases, significant increases in the use of testing. The other thing we had was a use of both monohydroxy, or 1-hydroxy and 1,25-hydroxy vitamin D. Now the reality is the 1-hydroxy test is a better reflection of the stable, the homeostatic calcium vitamin D metabolism in a patient. So that's what you really should be doing first, except in certain specific clinical circumstances, some granulomatous disease, some malignancies, kidney disease, and some genetic disease like genetic rickets. So the situation really evolved that for us, it would be appropriate to take Dr. Lervy's policy. Now, the concept of collaboration, contractors working together to develop policies, is not new. It has gotten a lot more attention lately, but it actually goes back to the 1990s and the reference that I gave you in the Program Integrity Manual. So when you look at the manual, you'll see that we're directed, before developing a new policy, we're to look around and see if other contractors have that policy. But the problem is, in jurisdiction K, we had not applied limited coverage or direction to the use of the two tests concurrently. So essentially, this is a limitation of coverage. But more importantly, as the 21st Century Cures Act is being applied, not only are we supposed to look at restrictions in a policy or limitations of coverage, we're also now directed to look at changes in coverage, even if they are affirming a broader coverage of services. So we are now being directed to expand the circumstances in which we develop a policy, to make sure that our thought process is as clear to you as it is to us. So that's a big change. So in this case, while I'm not sure that we're really constricting coverage, we are directing people how to use the test better and maybe more appropriate guidance on frequency. We are being told under the 21st Century Cures that we have to write that up. So that was new for me. So, you know, after 17, 18 years of doing it, I was like, oh, I'm just going to take Noridian's policy and I'm going to just repackage it. Can't do that anymore. So I used Dr. Lurvy's material, but I also consulted Dr. Craig Haug, who is in Boston. He's part of our fold and somebody I work with on a daily basis. And I went to a former mentor and friend, Dr. Charles Haley. So again, a Noridian person. Do you know Dr. Haley? By any chance? Okay. And the reason I sought them out was because they, Dr. Haley was a CDC researcher on diarrheal diseases before becoming a medical director. And Dr. Haug, as probably those of you from my jurisdiction know, was an academic transplant surgeon at Mass General before becoming a medical director. I've had the pleasure of writing a couple of things over the years, but not anywhere near as extensively as they have. So I went to them about how to develop the literary base on what I was doing. And what used to be kind of a cut and paste job done in a few hours, I wound up spending a weekend reading at least the abstracts of 47 policies that Dr. Lurvy had assembled a number of years before. And then, because the 21st Century Cures Act mandates an update to more current literature, I added 7 references, including something from AHRQ, something from the Internal Medicine Foundation Choosing Wisely initiative, and I used those 7 references to explain why I chose that policy. So if you're good enough to look at this draft and comment, you know, please be gentle because this was my work, but our policies now require a summary of the evidence and a rationale for the determination. So I can't just say, I'm doing this because my friend out on the West Coast is doing it. I can't remain silent and just take his limitations of coverage and implement them as our own at NGS. I had to go back and develop an analysis of a summary of the evidence and a rationale for why I thought the way I did. And if you look at it, it may actually be the dominant component of the policy. So a simple rewrite and adaptation of a policy wound up being about a 3-day effort. Some of the things we're doing to respond to this, or what I'm doing here, which is talking to our CAC reps about it from the different specialties, that when you come to us to discuss things, we appreciate the informality and the personal relationships. But it's now a more formal relationship. It's kind of like filling out a dance card or, renting a tux before you come. You're going to have to go and get the literature. And doing stuff like saying, well, the CAC reps wanted it. Not as good as it used to be. Talking about scope of practice. As we see sometimes, scope of practices in different states are different. And I'm going to finish up in a second, and then I'm going to get questions, so I'll get you first, sir. So basically, it is going to take a more formal expectation of commentary from you folks who are kind enough to support it. I think things are going to be a little more evidentiary based. One of the things we've done, the Noridian docs started, we work closely with them because we're kind of like big ones on the opposite coast. They started using a program called EndNote, which is a way, I don't know, are any of you familiar with EndNote? Okay, we just had them approved and installed on our laptops. And what we do is we actually work on bibliography development in sync. It is a way that I can develop a library, relate a bibliography for my policy, and maybe my other colleague in JK, Dr. Steve Boren, is working on it. He can supplement my library remotely. So we are in the process, and probably we're going to do this cross contractors. So this is a major difference in the way we're doing things. The other thing that I wanted to bring to your attention, when you go look at the vitamin D policy, there's an ESRD policy. Again, not directly related to podiatry, but I will bet that in each of your practices there are some patients who have bone disease related to renal disease, and they are challenges in your practice. But this policy is unique in the sense that it was developed in complete collaboration. There were some issues coming up over the frequency of hemodialysis, and one representative from each contractor set to work on the policy. So we've done some stuff in the past where, we developed a policy, somebody else liked it, what I just did with Noridian's vitamin D policy, and then other contractors took it, essentially in toto. This one, we actually developed it together, and we are the commentary period. There is a limit on the minimum number of days where we can be collecting your comments. But on this particular policy, we have kept, there's no limitation on how long you can keep your comment period open. So what we're doing is, I think it may be CGS is the contractor. Do we have any CGS folks here? Kentucky, Ohio? Great, welcome. I want to give you greetings from all of us from around the country, and we thank you for your help. I think they are going to be the last to close. I don't know, do you know when your comment period is going to close on the I think it's like December 15th. So we are keeping our comment period open a month longer, and then we are actually going to review the comments that we have received as a group. So that is another major departure. So essentially, we're going to ask you to take your role as the advisory committee even more seriously, because the literature and the comments that you provide to us are likely to be going to other contractors and essentially impacting the entire Medicare population. I'm going to go through the slides, and then I'm going to allow you some time for questions. Okay, the three major objectives of the advisory committee. One is what we're here talking about, the development of the coverage determination in an advisory capacity. Two, discussing and improving administrative policies within the discretion of the contractor. So if there's something that you see that is negatively impacting podiatry, not your practice per se, there are other mechanisms to solve your individual claim issues. But if you are having problems with one of our policies in the jurisdiction, you are supposed to be the ombudsman for your colleagues. So, and also a forum for information interchange. And that's, again, sort of what we're doing here today. Today is actually a fulfillment of your role as CAC reps, because we're here to talk about some of the changes in policy development in the fee-for-service Medicare program. And as I said, the CAC is not someplace for discussion of individual cases or individual practitioners, with the exception if those cases are reflective of problems within the jurisdiction, then we want to hear about it. And for example, Dr. Fine was talking about a claim denial, doing the right thing, representing his constituents, and we had erred in the way that our reviewer had looked at a code. Now, if it's one claim, that's fine, but if he's bringing to my attention that our reviewers may be doing something incorrect, or if we have a system error that's denying a code that should be paid, well, that is part of your job. The other problem we have, and you'll notice I also said fee-for-service Medicare. Medicare Advantage plans are supposed to adhere to our basic tenets of coverage. Unfortunately, I know up in New England, Craig has a good rep that comes pretty often to represent the Medicare Advantage plans. In New York, we're pushing a little harder to get some regular participation. The Medicare Advantage plans are supposed to have parity in terms of what they cover. I know, unfortunately, that doesn't always happen. I don't want to criticize them without a representative being here to defend their position, but they do. I think it's kind of an expectation on their part that they are allowed to use more of the, prior authorization models, closed panels. They are applying well-known business techniques to hold down cost. And that is not really as permissible, although even in original Medicare now, we are looking at some prior authorization models. We are working on one out in Illinois on ambulance transportation of patients and prior authorization. We are, and this applies, I think, to some podiatrists, and you may be hearing feedback from Illinois, we are looking at prior authorization of hyperbaric treatments. And that is something that may be extending beyond that jurisdiction. But there is not always parity. I'd be a liar to say that there's complete parity between Medicare Advantage and the plans that the carrier medical directors represent. And so we're trying to get people to the CACs, but it's hard to discuss their policies in the absence of a representative. But still, I think it's important that you bring it to our attention. your responsibility, should you accept this mission. We are doing a lot. Like, I know Dr. Keating is always there on the phone when it counts. Sometimes we've had difficulty getting people into Manhattan. We moved from our lower Manhattan location up to Memorial Sloan Kettering, not just to maybe have better parking available to us, but to have technology available. And we are trying to get, and I appreciate the forbearance of the folks in Connecticut, we're trying to get better connectivity from the state medical society offices. We do have a good technologic base in Waltham with the Mass Medical Society. So we are trying to bring the CAC to you so that we understand the time constraints of the time. We also understand that many of our practitioners are salaried now. They are working for institutions and systems. And so we understand that they don't always have the same discretion that they used to take off from their own office. So we're doing a lot of things to reach out for participation. So please, if you can't be there in person, almost every contractor now has accessibility via electronics. So also talk to your alternate, get to know them, even I would say have a third person in the background in development. I noticed the GI societies in New York and the anesthesia societies, as some of their members became more senior, they would occasionally ask, could a guest come to the meeting? And by prior arrangement, and I think most medical directors are pretty liberal about this, we will allow guests from a specialty. And that way people became familiar with the process and seamlessly slipped in to take on the role. So I commend that thought to your attention. Another thing that I neglected to mention, someone asked at the HEMONC meeting, do you foresee 21st century bringing more policies or less? And the honest answer is probably a little bit less. And that reason I explained is it's going to take a little more effort, a little more thought to display our transparency and to have the appropriate bibliography. So the policies are becoming more formal documents. That isn't to say that we don't give deference to our advisory committees, nor to local standards of care, but I do think there's going to be a higher evidentiary base. The other problem that we have, and we have been talking about, can we get a little wiggle room on this, is we are now required to take our draft policy, and before it goes into its public-facing draft, CMS has asked that they have an opportunity to review it for 21 working days. If you do the math on that, 21 working days comes out to a month. I mean, factually, it's going to take a month. So if we do the math on it right now, I mentioned two of our policies with the ESRD one getting a whole lot of comments. We're analyzing those comments. At the same time, for us to present new policies to you mid-February when we're scheduled, we have to add in an entire month of preview time for CMS before we hit the 14 days in advance, either electronically or if you specifically request paper documents. So we need to give you, as thoughtful commenters, 2 weeks notice on the policy, but we now have also had effectively 4 weeks to CMS, which means that we have to have the policy public ready 4 weeks earlier than we used to. So what we are doing, there's a 6-week time prior to the CAC where we have to have our drafts finished. So effectively what that means is we are looking right now at next generation sequencing in myeloproliferative neoplasia at the same time that we are reviewing thousands of comments coming in on ESRD. So our jobs have become more difficult and maybe in some ways more policy focused. So we ask your forbearance. There may be a topic that is burning for you, but maybe somewhere it's in the hopper, and it may take an extra 4 months for us to get to it. Last thought, which I italicized here, if you feel that something related to your specialty involves specific expertise, I'll give an example of Mohs surgery related to the general field of plastics. And you feel like you want somebody, if you want somebody with specific surgical expertise to discuss a podiatric issue, call in advance and we can arrange for a guest presenter to accompany you either in person or on the phone, because really that's another part of your roles, being a conduit to the expertise needed for policy. And again, I go back to Dr. Haley and the first CAC I ever attended. We used to have a Trailblazer, a preamble that we would read at every meeting, and it included the sentence, "It is this interspecialty discussion that we often value the most." Someone who is on the advisory committee passionately arguing for their beliefs frequently has, bought what they're doing hook, line, and sinker, that they are fully committed to something that they have been involved in, and we understand that. But on the other hand, someone from another specialty may say, well, I've seen this in use in my practice or my facility, my hospital, and it really isn't working out so well. And I think that that balance is what really makes this deliberative body a great exercise. The other thing I'll mention to that is, how many of you know what the open CAC is? Okay, what happens now, and this has been in effect maybe for 9 or 10 years, but it is becoming more effective. We had a great one on the concept of dialysis. We had patients, we had dialysis staff, but we also had academics providing arguments on the frequency of hemodialysis and its benefit or lack of benefit to patients. And the discussion was really, it could have been a lecture that I went to. The level of discussion was so good. And if you feel like, looking at our policies, if you think that something particularly pertains to podiatry, find out when the meeting is. It is open to the public. Just come on as a guest and listen in, because what you may find is industry representatives, stakeholders, patients participating in these calls and really amplifying your background in the discussion. So, I think that I have to say this is a great job, and I just like there are very few people that I encounter that I don't enjoy working with. But the way to really improve the relationship is to understand where we're going and these recent changes in the way we're working, and be willing to take the job on with the understanding that there's going to be a little more academic work and a little bit more heavy lifting so that we can assure the transparency of the policies. And again, staying up with the times. I gave an example. If you personally don't perform home care visits, And yet we know this has been an example for your specialty. Then try and talk to your regional organization. Find out how many practitioners are doing this service, be the conduit for the problems and concerns, and do the background before the meeting. So if there is a concern over payment issues related to home care podiatric services, be prepared to help us with some factual data. And again, I spoke about this already. And those of you who go to our meetings, Craig always concludes, Dr. Boren always opens with a reminder, which I totally agree with, that serving in your position is a privilege, and it's a privilege for us to work with you. And Dr. Haug always concludes with Woody Allen's, 80% of success is just showing up. So on that, I will conclude, and I think I've done it right. I think I've left at least 20 minutes for questions. So I'm sure there's something. You were first, sir. Okay. And why don't you introduce yourself so I know where you're from?
Dr. Mark Block, Florida.
Florida. Okay, that's Juan Shaning.
Yes.
And Alicia Campbell.
Yes. Two questions. Number one, regarding the 21st Century Cures Act and having to meet certain criteria, parameters, substantiating, I guess, basically that the policy is based on sound data. That being the case, I understand moving forward that that's what's applicable, but retrospectively, is that also being applied?
Okay, good question. We are not able to go back and redo everything. In other words, there's not going to be wholesale changes to existing policies, at least in the present. But I think my example of the vitamin D metabolism, I picked it for that reason, is when you do now readdress an existing policy, you have to change the format. So let's pick an example germane to podiatry. What's a local one? I know there's some of the national ones. A debridement?
Debridement.
All right. In the future, if a wound care or debridement policy was essentially challenged by a request for reconsider, not a formal legal policy challenge, but a request for reconsideration of codes on your part, the redo would have to go into the 21st century format. So whichever contractor, Florida First Coast, if they were going to take it on, they would have to review the literature and provide updates. So yes, if we go back, if they're existing, they're existing. And we're not gonna pull the rug out from people who have become used to policies. But if you're gonna go back and revise, then it's usually going to go through the advisory process and through the 21st century reformatting.
Well, along those lines, another question comes up. Who requests the revision? Does this come from the carrier? Does it come from the providers? Does it come from both?
Any of them. If you feel like there is a code that is neglected from a policy, that would be something that you would bring forward to us. Now, we would request at least a couple of pieces of literature that support what you are doing. Now, in a pure expansion with no controversy, one simple code, we might not have to revise the policy. If there's a major change, and unfortunately the word major is kind of ill-defined, but if you were, as I said, when we started talking about where you should order one type of test but not the other, that's a difference. And we were obliged to bring that back through the 21st century cures. So the answer is that changes may bring a more formal revision than it did in the past. Does that help any?
Yes, Thank you.
Okay, anything else?
Second question, totally off that subject, has to do with the Medicare Advantage plans.
Yes.
Language commonly comes up when challenged as far as them adhering to the existing LCD, and the language, I'm kind of paraphrasing it, generally comes up is that it's generally expected that they adhere to it. What really does that mean? I mean, it's not that definitive. It's not, no pun intended, holding their feet to the fire, so to say. It gives them a lot of latitude. So where do you draw the line? Where do you say they're not adhering?
Well, you and I are both asking the same question. That's the difficulty. It is generally expected. And then they say, well, one of the differences is inclusion in clinical trials. Usually the patient is transferred to original Medicare coverage. There are some provisions for participation in clinical trials. So there's a difference right there. But the other problem, I hear this, is that, for example, provider network issues come up, application of some of the managed care paradigm, the concept of prior authorization, the concept of prerequisite tests being ordered before going on. Some of that is generally expected, and we can talk things over with Medicare Advantage medical directors, but we don't have direct ability to direct them to, you have to cover this. That's out of our hands.
Okay.
So it's a tough situation sometimes. Usually they're pretty good, and usually I like the fact that in New England, the Medicare Advantage plans have designated someone to come to the meetings, and hopefully we're going to get that in all of our states, in both jurisdictions.
Great. Thanks very much for your time.
My pleasure. Sir?
Yeah, Mark Clark, Mark Dollard from Novitas.
Yeah, how are
doing?
you?
I thank you for mentoring me back in the 90s and all of that. We go back long ways.
Yeah.
Let me give some perspectives that we've had here, if I could, Dr. Clark.
Sure.
You talk about evidence-based medicine being the basis for decision-making.
Right.
But we're having a problem where all of a sudden we've had a whole sling of LCDs being thrown at us and a very limited time to get the resources to get that evidence-based medicine during the commentary periods. And it's becoming overwhelming, and it just being wound care, RFC, skin substitutes, injections for pains, and we just don't have enough manpower to get it out during all these periods of time. How can we put a halt on this?
Well, actually, I think the process that I described, I was being honest, that I do think that the evidentiary bar and the summary of evidence that we're required to do is going to slow things down a little bit. I do think that we're going to be more deliberative and more thoughtful in what we do, and we have to give you that explanation. So I think that, on issues, and the other thing that I mentioned, which is of interest, is actually attending the open meeting, seeing who may have industry literature on some of this stuff. I do think you're going to find the process slowing down, being more deliberate. I'm surprised. I don't think, if I ask Mike or Dan, I don't think you've found us to be a blistering pace, have you? No, interesting. So Novitas, honestly, we have been kind of caught up in molecular diagnostic issues, in dialysis issues. I do think we may get drawn. I'm not sure. It may be that we default to the NCD on hyperbaric oxygen. The other thing is probably going to slow things down a little bit. And certainly there's a number of NCDs that impact podiatry. And one of the problems that has surfaced in the year following the ICD-10 conversion is the fact that sometimes these crosswalking of codes has not really been optimal. So we are trying to help CMS. We're revisiting some of these problems. I think that issue is going to detract. It sounds like you've really had, what is that, like skin substitutes, wound care have been big issues in the Novitas jurisdiction?
Oh, sure, yes, yes. Debridements, injections for pain, low extremity pain, and strappings, and it just goes on and on and on, routine foot care. But, you know, we're still hit with that 45-day commentary period that we still have to adhere to. If we don't get our materials in, boom, it is what it is, and it is what the draft is. And what happens, I think, sometimes is the way it's being managed now. We used to have some nice face-to-face meetings. Those are great times. But now it's a lot of teleconferencing, telephones, and you really don't get to see the raised eyebrow, the gestures that get off the clues to some other specialist to come on board. Because oftentimes we had some relationships with orthopedics, dermatology, and we just don't see them face-to-face anymore. And I know in our area, we no longer are given the contact information, the emails, to really work with the other specialties like we used to face-to-face. I think these are some issues that are hindering us a little bit in moving forward.
That's interesting. Again, I'll go to Mike and Dan. I don't think you have too much of an access or communication issue. Do you feel that? I mean, tell me if you do.
But you have face-to-face meetings, yeah, and they supply you with the full email contacts and all that, with all the other specialties.
I'll tell you, Mark, what we do is kind of, and maybe, you know, in February when travel is more difficult, we have kind of a nodal meeting. We use the auspices of the Medical Society of Connecticut, of Massachusetts, and I use the auditorium at Sloan Kettering. And we kind of do a webinar, phone, live. And, you know, we might in February, if, you know, we don't have a large projected turnout, we might change things, but, Michael, do you want to comment?
Yeah, you're very lucky being under Larry Clark. Let me tell you that.
You know, I will tell you, Mark, you know, I appreciate Michael's comment, but, you know, it does help. You know, as I said, there's an extra month when our policies have to be reviewed before the public-facing document gets released. But that should, in some ways, also give you time to kind of research or try and look at what's coming, so at least you are aware. Who do you work with? Dr. Hayes, Dr. White? Who's?
Hayes, White, Dr.
Who?
Yeah, sure.
Sydney? I think I would just maybe, I don't think those folks are unreasonable. I would ask maybe just to, if you heard about the model that we use for communicating, that we have a place just for CAC reps. Sir.
Hi, David Friedman with Maryland. Thank you, Larry, for being here. Quick question on MUEs.
Okay.
So the medically unlikely edits, we're noticing issues with the numbers that have been allotted by CMS that seem to be unreasonable in certain cases. And then I'm seeing in some policies that there's limitations here with Novitas, that they're limiting certain CPT codes that are not equivalent to the MUEs that are on the CMS website. For example, there may be a CPT code that's limited for 2 units on their LCD policy, but when you go to the MUEs on the CMS website, it says 13. So there's things that are happening locally with the carrier that are separate from CMS. So I don't know if you can comment about MUEs,
Sure.
what the carrier can do individually versus what's on the CMS policy website.
Okay. Well, you know, that's scary. I hope you're exaggerating. There a difference between 2 and 13, because that's huge. I mean, that sounds to me like the MUE is being applied to something other than the correct CPT code. Now, the MUE and the, you know what the correct coding initiative is. And essentially, MUEs are a CMS function. They're not ours. And so, you know, and some of them are subject to change. Medicine's evolving really rapidly. We have had some problems. I'll give you an example from JK. We had problems with multiple unlikely edits on hemophilia factors. And they were outdated, and they were applied to patients who, because of body habitus, weight, size, needed more factors and were legitimate. And actually, we were able to talk with Dr. Rosen and the folks that oversee some of the CCI edits and able to straighten out some of these things. I don't know. I think maybe what you need to do is to talk to your medical director about what's covered in terms of the CMS editing and what's covered under their editing. If you're having that much of a disparity between 2 and 13, something is being applied to a wrong code or a wrong
But are you, as a
medication.
carrier, allowed to restrict utilization of a certain CPT code when, like in that situation where we're only allowed 2 of these when really more should be allowed? Can you do that as a carrier?
Yeah, we can, but that's more under a determination of a frequency edit. And frequency edits restrict coverage. So they are supposed to go through the advisory process. Now, CCI edits are exogenous and are developed by CMS. So what you can do is, I think it's fair game to discuss with your contractor so that you're sure that you have a good understanding of what is an edit that they're responsible for and what is an edit that they are not responsible for. But restrictions on the frequency of a service would have to be determined in the context of a policy, and that would go through a period of notice and comment.
And then one more comment, and I'll let Paul ask because I'm hogging the microphone. So if you do have an MUE issue, is there specifically someone there at CMS that you would say is the person to go to? Is this a Niels Rosen thing, or is this who is like the person or the contact at CMS for MUE request reconsideration?
Can you, I'll see if I can help you with this. What is the specific service that you're having the problem with?
It's for 87798.
Help me with that.
That's CPT code for organisms that are being identified that don't have a specific name because they're not listed in the CPT book under which you brought up before, which is next generation DNA sequencing.
Okay. So you are doing that, or are you sending out?
Yeah, lab is, so it was just a comment because of consulting.
Okay.
Yeah.
So you're talking about lab MUEs.
Yep.
I need to look at that. I wasn't thinking that when I was thinking podiatry. So let me look that up for you,
Yeah.
and I will see if I can get back to you on that, okay?
Thank
Have you talked to your medical directors about that?
I'm sorry.
Have you talked to Dr. Hayes about that?
No, we would probably bring it up to Dr. Patterson.
Oh, Deborah, okay.
Yeah.
Well, she and Dr. Haley and I were back together at Trailblazer. She is really pretty principled and pretty by the book. I need to look at the specific implications. That's a laboratory, not a podiatry service, and I need to look at that. I'll try and get back to you on that. Sir, thank you. Sir.
Kinberg, Texas, former Trailblazer, now Nobel.
Yeah, right, hello.
Okay, so I appreciate the CARES Act, and we talked about the PIM this morning at our orientation, and I very much appreciate you doubling the CAC salary. But you get my drift on that.
Yeah.
We need some help when we're looking at LCDs. I've asked for years to see strikeouts. I've asked for years to have highlights so I can see what the changes are, so I don't have to try to contrast and compare 2 or 3 documents at one time, because we're not being paid for this. We're voluntarily giving our time to our profession and to the government to provide this service, and I for one would like a little help in being a little more effective in getting this done.
Well, that's a great question. I'm going to be honest with you. I don't see the money readily available, Paul. I just don't.
I mean, you're kind of doing that now when you're rewriting an LCD, don't you?
Well, I think we're rewriting it even more than you're talking about. I mean, if you look, the rewrite on vitamin D, the strikeouts would exceed what was left of it. I think there's going to be major and wholesale changes when stuff comes up. Would you like to see our working notes in terms, I mean, I don't know that I would have any problem with that, so that it would facilitate contrasting with the pre-existing LCD.
Yeah, just something that would help us provide the documentation that you want, because I like a number of people here, write those letters with the footnoted references and provide you with all that stuff, and just to lead me down the track so I know where you want to go and where you're coming from would sure help me out.
That's interesting. Well, thank you, A, for your years of service, and B, I do think, I don't know, I would have, and I certainly am not going to speak for other contractors, but, I've talked to you a little bit about what we're doing to share references in the development of our bibliography. I wouldn't care if you had my working notes. I don't know, I don't want to speak for any of my colleagues, but if you wanted to see where the changes were to facilitate what you're doing, I don't know that that would be unreasonable. But thank you.
Jeff Korst, Illinois NGS. Say hello to Steve Bourne for me.
Yeah.
Go
ahead.
I have 2 questions. The first question is, E&M visits, especially new patient visits with nail debridements. This has been going on for over 3 years with NGS, and I'm trying to figure out why does that keep happening. I just reviewed another case, sent it to my medical director, Caroline Cunningham, and they downcoded this doctor from a 99203, had 3 pages of notes. To me, it looked like a legitimate request that, and did nail debridement at the same time. They downgraded it to a 99201. So what's the thinking there? Is that it's been happening too often? But on a new patient, that's totally different than an established patient.
All right, let me try and break that down. Are you speaking for yourself? Are you speaking that in J6 this is a problem?
For J6. People in J6 experience this over the last 3 years, and I'm still trying to figure out,
JK?
J6.
I'm going to ask my JK folks, though, are you aware of this problem? I haven't heard about this. Dan? Okay.
Excluded? So that actually brings up even a better question. Why does it happen in my jurisdiction, which is NGS, and not in the whole of NGS?
I will bring that issue up. But the other thing, before I say anything, I like seeing the clinical examples. And remember that the requirements for E&M services, and you do know that there is sort of a national initiative to try and reduce provider burden. So I think there's an effort to be clearer on this. Do you really feel, I'm asking you straight up now, just the 2 of us, do you feel that all the requirements of the 3-level visit are met in what you are doing in terms of understanding anatomic limitations that you have based upon your scope of practice, et cetera, do you really feel that you have reached that in terms of the complexity, the medical decision-making of the visit?
Absolutely, especially when, I'm dealing with like complex patients, like diabetic patients that have a foot wound, that have to talk to the nephrologist, they have to talk to the infectious disease and vascular surgeon. Absolutely. I have no problem going to level 3.
Then I think, you know what I'll do, since this is my contractor, I will ask you to I'll leave a few of my cards
Okay.
at the end up here on the podium. I usually do that. Send me a couple of examples so that we can, I'm a little...
And sometimes it's not even, they pay for the 11,721 and they don't pay for the E&M visit because they say the E&M visit's part of the 11,721, part of those evaluation services, so. I have
All
another
right.
question. Can I ask you another question?
Okay, one more question, and then I think our next speaker is coming, so...
On behalf of Dr. Root here, she wants to ask a question about term limits for CACs.
Okay, it's up to the CAC. Usually it's recommended to be 2 or 3 years, but that's not an absolute. But I do think most of us use a 3-year, but remember that it's your organizations that refer the people and endorse them. It's not us to be choosing or picking. So you talk with your own local organizations, your state organizations, and develop a process to endorse the rep, okay?
All right,
Hey, thank you all very much. I appreciate it.